Namaste and hello everybody. Let us begin with one of the very important topics in the larger domain of cardiovascular system in pharmacology, and that is the management of CCF. CCF stands for congestive cardiac failure, and we will be seeing mainly cardiac glycosides here. That's why the things are there, but otherwise we will be seeing the whole management of congestive cardiac failures and drugs along with cardiac glycosides which are there for the congestive cardiac. So this is the purpose statement. At the end of this particular presentation, we should be able to classify the drugs which are used for the congestive cardiac failure. We should be able to explain the mechanism of action of the drugs for the congestive cardiac failure, and we should be able to describe the clinical profile of the drugs for congestive cardiac failure. These are the learning objectives, and these are the things from the must know domain which are there. Describing the history of cardiac glycoside, describing the pharmacological actions of cardiac glycosides, explaining the mechanism of action of cardiac glycosides, clinical profile, and finally explaining the clinical applications of cardiac glycosides. Now, before going on to see the cardiac glycosides, let us first see what we mean by congestive cardiac failure. First thing is to be remembered that congestive cardiac failure is not like a heart attack, which is a sudden thing. It's a chronic thing which happens for long duration of time. It has a long span. What it is exactly? It is when the heart fails to pump the blood adequately for the body. That is called as congestive cardiac failure. And what is this word congestive? Congestive means congestion. What will be happening if the heart fails to pump the blood? From right ventricle, if it is not able to pump the blood, it will accumulate in the left ventricle. Left ventricle, it will go on accumulating in the left atria. From left atria to the right ventricle and then right atria. And in between there is a lung, and there is a congestion of lung that is being there, that is congestive cardiac failure. And again there will be edema that will be developing on the dependent part of the body, and that is what is the congestive cardiac failure means. And this happens slowly over the long duration of time. It is not something which is suddenly occurring as in the case like myocardial infarction and all. So let us be very clear about the difference. This is not something which is the myocardial infarction. It is something which is congestive cardiac failure. The heart is not able to pump the blood adequately for the body because of many reasons which are there, and which is a chronic condition, that is a congestive cardiac failure. And what are the drugs which are there in our armamentarium for the treatment of this congestive cardiac failure? Undoubtedly, the first and the foremost group of the drug, that is the cardiac glycosides. These are the cardiac glycosides. These are obtained from the plants Digitalis, Trophanthus and squirrel species, and have a specific and powerful action on the heart. What is the specific action and what is that powerful action? That also we will see as we will move ahead in this particular presentation. Now there is a very interesting history towards it, how the cardiac glycosides were discovered. This congestive cardiac failure leads to the edema, as well as there is accumulation of fluid in the abdomen, that is called as dropsy, right? And previously the dropsy was almost untreatable disease. It was way back in 1776. The story goes way back to 1776, when this dropsy was considered almost untreatable disease. There was a physician, and he was botanist too, right? William Withering. He was practicing in England, and one of the patient came to him and he diagnosed the patient as having the dropsy and told him the prognosis that, see, as for now there is no treatment for this. But the patient went away after listening to his advice and came back after few days absolutely okay. And now this William Withering was surprised to see the patient that at one point the medical science says that there is no treatment for this dropsy, and at this point I can see the patient who has come there absolutely all right, or not having now dropsy anymore. When he inquired, he said that I took one abstract or kadha, that is what we call, right, from one lady, and she gives this particular abstract to number of people who suffer from dropsy, and miraculously they get cured. William Withering got inquisitive. He went to that lady and he found out that this lady used to prepare that abstract or extract from 20 herbs. She used to take the 20 herbs, right, take them together and used to extract the active principle from them and used to give that particular extract to the patients, and patients used to get all right. Now he studied all the 20 herbs, and what William Withering found out that only one herb was that of importance, less 19 were not of any use, and that one herb led to the development or the discovery of these cardiac glycosides. So this is how the history. Now what was that plant which was very much helpful? The rest 19 were not. This was Digitalis purpura or purple foxglove, right? So this Digitalis purpura with beautiful purple flowers, as you can see, from this Digitalis was obtained. The active principle was obtained, and that was Digitalis, and here you can see a kind of portrait of William Withering. This is not a photograph. At that time photography was not there, and this was a kind of portrait of William Withering, right? And he found out the Digitalis, and Digitalis was a breakthrough in the treatment of congestive cardiac failure, and a new group of drugs were born, and that is called as cardiac glycosides. They were used for the heart conditions even by Egyptians, Romans and early Europeans also, but obviously it came to the medical knowledge by William Withering. The cardiac glycosides are commonly found in the plants like milkweed, lily valley and all these things, but one of the important plants is Digitalis purpura, and that is the foxglove plant. What are the various cardiac glycosides? There is no very complicated type of classification which is there, thankfully, in these cardiac glycosides. So we have cardiac glycosides, the Digitalis preparations. The drug members are digitoxin. We will see what is the difference between digitoxin, digoxin. Digitoxin and digoxin are not one of the same, right? Though they are obtained from the same plant, they are a bit different, right? So let us see this. We will see the difference later on. Deselonoside, D-lanatoside, that is also called. What they do, cardiac cell experiences a rise in Ca+2 inside the cell. The force and velocity of contraction is greatly increased. What they are doing? They are increasing the force of contraction of the heart. Heart is not able to contract properly. That is what is the pathology or pathophysiology here in this case of congestive cardiac failure. This is the prime mechanism of action of all cardiac glycosides. If there is one mechanism of action, this is this. How they cause this mechanism of action, that we will see later, or how they cause this action we will see later. But what is the action? Is the increase in the force and velocity of contraction, right? One more thing can be just added without changing the heart rate. So if you just want to have in short what the cardiac glycosides do, they increase the force of contraction and velocity without changing the heart rate. So that is what they do. This is the chemical structure of the cardiac glycosides, right? Just for information, this is the chemical structure. What is the mechanism of action? At the gross level, what happens? Let us see. At gross level, we are not going into the molecular level, or we are not going into the cellular level. Cellular level is the next one, as you can see, molecular. This is the gross level. Digitalis increases the myocardial contractility, we have already seen. So if the force of contraction increases, obviously cardiac output is increased. What is the problem here in the congestive cardiac failure? There is no sufficient cardiac output. Here is the cardiac output increasing sufficiently. Relieves the venous congestion, relieves the backward as well as forward failures. We have spoken. Backward failure and forward failure, there is accumulation of the residue of the blood because the blood is not getting pumped properly. Why it causes the gross level changes? It is because we have to go at the molecular level. What it does at the molecular level? Before going on to see the molecular level, it is a general knowledge of the medical students that the heart contracts due to the cardiac muscles and muscle contracts when with the help of the calcium. You give more and more calcium and it will contract more and more with vigor. So what digitalis do? Digitalis inhibit a pump called as sodium potassium ATPase pump. Please remember this particular thing very clearly, because this is being asked repeatedly in the questions that which is the pump that is inhibited by D. So it is sodium potassium ATPase. There is accumulation of sodium ions within the myocardial cytosol. That's okay. But what this sodium do? It causes the non-removal of Ca+2 from cytosol to the myocardium, more and more accumulation of Ca+2, even if you remember that. And if more and more Ca+2 is available to the heart, it causes longer myocardial contraction. In CVS, in normal individuals, cardiac glycosides augment the strength and speed of myocardial contraction, obviously, and that is what they do in the case of failing heart too. In the presence of congestive cardiac failure, digitalis has the following action. Contractility is increase. Complete ventricular emptying increases the stroke volume, stroke output. Digitalized heart can do the same work with less energy, therefore called as cardiotonic heart. So it gives a tone, cardiotonic drug. These are also called as cardiotonic drug, tone to the heart, right, for increasing the cardiac output. That is what it does. And heart rate, when we described the mechanism of action in single sentence, we said that it increases the force of contraction of the heart and the velocity of contraction without increasing the heart rate. So heart rate is normal, no significant change in congestive cardiac failure. So the heart rate, even in some cases, it is reduced, right? So what happens that oxygen consumption by the heart itself get reduced. So with a less oxygen consumption, there is a bigger cardiac output and there is greater contractility. Refractory period, small doses, shortening of atrial refractory period, and large doses, prolongation of atrial refractory period. So these are refractory period, how it acts on the refractory period. That is what is the thing. Automaticity of the heart is increased, right? Heart is becoming more and more efficacious without significant increase in the blood pressure. Coronary circulation is improved. That is what is required in the case of congestive cardiac failure. Venous system lowers the venous tone, increases the peripheral blood flow. ECG changes, prolonged PR interval, inverted T waves, ST segment depression, shortened. Now inverted T waves are also seen in the case of myocardial infarction. So if you have a patient and if you come across inverted T waves, don't just label it blindly as myocardial infarction. Ask for the drug history, whether they are on cardiac glycosides, especially digitalis. Though better drug available nowadays, but yes, sometimes digitalis is being used and it causes inverted T wave. So there is another cause of inverted T waves other than myocardial infarction, use of the digitalis. Extra cardiac action, what it does? Kidney diuresis. More and more urine is going out. Why? Because stroke volume is increased. More and more blood is pumped into the body. More and more blood goes into the kidney, and kidney filters the blood more and more, producing more and more urine. And that is the reason why when William Withering studied the drug, that is one thing he saw at that time. At that time there were no ECGs, this, that, right? Echocardiography out of question. So what he observed was, in the patients there is increase in the diuresis. Patient began to have more and more urination. So he labeled it as diuretic. We know it is not, right? Primarily it acts on the heart and that's why it causes diuretics. Primarily it is not acting on the kidney. But previously it was thought that it is a kind of diuretic acting on the kidney. Stimulates the chemoreceptor trigger zone, may cause anorexia, nausea, kind of diarrhea in some patients. Oral absorption is about 50 to 80%, 65 to 80%, obviously, which gives us the clue that it can be given by oral route. Food delays absorption. We have to give a gap between the consumption of food and administration of this drug. Parenteral administration only during the emergencies. Nobody uses, but just this is for the academic point of view. Wide distribution into the organs and tissues including the CNS. Excretion, 80% of the drug gets unchanged in the urine, right? And dose individualization in the renal failure. So in the renal failure we have to be very cautious because it gets excreted through the kidney. We have to adjust the dose accordingly. In fact, what is being needed is therapeutic drug monitoring. That is something where we will directly judge the level of the digitalis in the blood, and that is what is the very recent mode of monitoring the drug effect. That is, we will directly monitor the drug in the blood. That is therapeutic drug monitoring. Small amount eliminated via active transport, renal, tubular and bile, and this importance of this obviously increases during the renal failure. We have to be very cautious administering of drug, otherwise it will cause toxicity. We had seen in the beginning that digitoxin and digoxin are not one and the same. There are pharmacokinetic difference besides the difference in the spelling, right? So there is digitoxin and digoxin. Let us see what is the difference. Oral absorption is very good in the case of digitoxin. It's just good in the case of digoxin, 60 to 80%. Here it is 100%. Plasma protein binding, digitoxin 95% and digoxin is only 20%. That means more and more active drug is available in the case of digoxin and not in the case of digitoxin, because when it will go into the body, it will mostly be attached to digitoxin, will be attached to plasma protein. We want free drug for the action, which is more in the case of digoxin. Onset, half an hour to 2 hours. Here the onset is just 15 to 30 minutes. More and more free drug is available. Plasma T half, 5 to 7 days, and here it is 40 hours. So long plasma T half, and that's why loading dose is necessary in both the drugs. Potency is least and digoxin potency is intermediate. Daily maintenance 0.05 to 2.2 milligram. Here it is around 0.5 milligram. Elimination is about 15% digitoxin and digoxin 35%. Route of elimination, here it is hepatic while it is renal. Administration is oral. Digoxin has advantage, it can be given by IV route also. Nobody gives nowadays, but it can be given by oral route, IV route also. Use maintenance, and this is a routine treatment, treatment, and in the case of emergency, because it can be given by IV route of administration, right? Adverse effects. Now these are the adverse effects which are there, and that's why the popularity of cardiac glycosides has come down, and availability of better drugs like angiotensin converting enzyme, AC inhibitors. So for congestive cardiac failure, what are the drugs of choice are AC inhibitors, in fact. Captopril, enalapril, lisinopril, all these things. We are going through this because our chapter demands that. Because our chapter is like congestive cardiac failure and the use of cardiac glycosides. That's why we are describing cardiac glycosides, and historically they are the first one drugs, right? And why their popularity decreased? Here it is, because its adverse effects. Extracardiac, abdominal pain, gastric irritation, fatigue, headache, blurring of vision, mental confusion. Then cardiac dysrhythmias, arrhythmias, they are occurring. Cardiac arrhythmias, the person is prone to have cardiac arrhythmias. There are deaths reported. Person will not die of congestive cardiac failure but died of cardiac arrhythmias due to development due to the giving of digitalis. Delayed AV conduction, heart block, ventricular tachycardia, fibrillation, all these things. So contraindicated in the case of cardiomyopathy, WPW syndrome, diastolic infection, AV nodal block, VTAC, ventricular tachycardias, and maxi edema, right? Here it is contraindicated. But the most fearsome adverse drug reaction is that of development of cardiac arrhythmias. Precaution, we have to see for hypokalemia, increases digitalis toxicity. So we have to see that, we have to monitor the potassium levels. Elderly, renal, severe hepatic disease, hepatic failure, renal failure, because mode of excretion is hepatic and renal. Thyrotoxicosis reduces the responsiveness to digitalis and prone to develop digitalis arrhythmias. So we have to be very cautious. And we have to be very cautious about the other drug interactions also. You can see here, amiodarone, erythromycin, quinidine, tetracycline, verapamil. They increase the digitalis concentration and may occur during the concurrent therapy. It might be very much possible that the patient is on digitalis and patient is also giving erythromycin to cure the upper respiratory tract infections. Or corticosteroids, thiazide diuretics and loop diuretics they also enhance the potential toxic effects, cardiotoxicity of the digitalis. So there is another point here, that how much we will have to be cautious whenever we will be giving the digitalis. So medical fraternity was just waiting that the new drug comes, we will just put this drug on the back seat, and that came in the form of SC inhibitors. So now the digitalis and cardiac glycoside, they are at the back seat as far as treatment of congestive cardiac failure is concerned. What is the treatment of intoxication in the case of cardiac glycosides? Hold the medications, don't give the medication further. You are sure that this is medication causing it, why to give it? Observe the other parameters, potassium levels, bradycardia, ventricular extrasystoles, and finally we have something called as FAB fragments against digoxin. They will go and bind to the digoxin, reducing the digoxin free levels in the blood. FAB fragments, antibody. Therapeutic indications, chronic congestive cardiac failure with chronic arterial fibrillation. Digitalis is the drug of choice. Chronic congestive, even if congestive cardiac failure, it's a chronic type of a manifestation, and with sinus rhythm. What can be given along with the digitalis are diuretics, or along with cardiac glycoside, diuretics, right? No doubt, cardiac glycoside themselves, they will increase the urinary flow, or they will cause more and more urine output, but diuresis is also required because the edema is so much that we want to decrease this fluid overload. High ceiling diuretics like furosemide, bumetadine mobilizes the edema fluid, edema decreases, increases the fluid load, improve the ventricular efficacy. Remove peripheral edema, pulmonary condition also is being removed. Chronic diuretic treatment may lead to hypokalemia, alkalosis, and carbohydrate intolerance, but that will occur after long duration of time, right? So diuretics are also added along with the particular therapy. Vasodilators, which are the vasodilators? That is hydralazine, minoxidil, calcium channel blockers, nifedipine, potassium channel activators, openers sometimes, that is called as nicorandil. Venodilators decreases the preload like nitrates, veins are dilating, decreasing the preload. And mixed dilated AC inhibitors, we were speaking about this when we were discussing about cardiac glycoside. These are the drugs nowadays that is given, right? AC inhibitors, captopril, enalapril, lisinopril, then again losartans and all these things, nitroprusside, right? These are the other drugs which can be given for. Now here are the drugs, very important slide here, beta blockers. Now beta blockers, there was one time when beta blockers were contraindicated for the treatment of congestive cardiac failure, because beta blockers, what they will do, they will decrease the force of contraction, then they will decrease the cardiac output. Already the cardiac output is less, you are giving beta blocker, absolutely contraindicated. But there is a paradigm shift to this particular notion in the medical field. That is, nowadays it says that in the early congestive cardiac failure, if you give beta blockers, it reduces the mortality. It is because it reduces the sympathetic outflow and sympathetic overactivity. But mind you, it is not given in the case of severe and very severe kind of congestive cardiac failure, it is still contraindicated. But level 1 or early congestive cardiac failure, yes, beta blockers are now indicated. That is how there is a sea of change. There is almost a paradigm shift about how we look at beta blockers as far as treatment of congestive cardiac